This program is brought to you by Emory University.
This program is brought to you by the Emory University Center for Ethics.
Hello, welcome everyone to this Healthcare Ethics Dialogue. We're really happy to have you, and this is the third that we've had of this year, this season, and look forward to more to come. Really happy to introduce our speaker today. So Renee McLeod Jordan, who is the founding dean for the School of Nursing at the Morehouse School of Medicine, and we're so excited to have you. She served previously as professor and dean of the Hofstra Northwell School of Nursing and PA Studies, and associate professor at the Zucker School of Medicine, as well as the director of the Division of Medical Ethics at Northwell Health. She's board certified in family, palliative, and acute care nurse practitioner, specializing in HIV, gynecology, and critical care. So just an amazing assortment of skills and specialties. We're excited to hear from her about her background. Her many leadership roles, I wish I could spend the whole afternoon just telling you this, but she was a member of the American Nursing Association Professional Issues Panel Advisory Committee for the Code of Ethics. She's a distinguished fellow for the National Academy of Practice, the New York Academy of Medicine, the Academy of Medical Educators, an active member of a number of important academies and groups, including the American Nursing Association, American Academy of Nurse Practitioners, the American Society for Bioethics and Humanities, the National Board of Respiratory Care, and more. I have the pleasure of serving with Renee on the board for the Association for Bioethics Program Directors in the United States and Canada, and it has been just a privilege to have the chance to work with you. She also has served and co-led the Racial Equity, Diversity, and Inclusion Task Force commissioned by the Association for Bioethics Program Directors and co-authored a very important article in the American Journal of Bioethics with recommendations from the task force, which I can encourage you to read. And also, she's currently serving on the board for the Council on Program Accreditation for Clinical Ethicist Training Program. So clinical ethicists are moving forward in terms of their professionalism and eventual certification and maybe licensing someday. So this board is developing accreditation standards for clinical ethics fellowship programs, so really seminal work for us. So please join me in welcoming Renee to the podium. Thanks.
Thank you, Kathy.
Thank you.
Thank you enough.
Thank you.
I think one of the main reasons of being in Georgia is having like minds, and I'm so grateful to Kathy for all the work that we've done together. So I'm going to say one of the greatest things that I've done with my career is being an ethicist. And so throughout this talk, I just want us to channel our inner ethicist. And we've all had inner ethicists as we were children, right? What's the first thing that we learned as children, right? The golden rule. Do unto others as we would have them do unto us, right? But we know that every golden rule has another side. And what I always like to say is I treat others as they wish to be treated, which sometimes is very different than do unto others as you would have done unto you. And so as we talk about, trust on trial, remember that trust is something that's very personal. And how we receive trust and how we give trust is mired in a lot of interpersonal issues. So thank you. I think we want to talk about trust, but trust in terms of misinformation. And now let's see. Yes, I am. Okay. So here are my session objectives. I won't belabor the point, except to say that one of the things that we're going to talk about from a clinical ethics point of view, how do we restore and build trust? And so we've all kind of seen this, right? In our children, in our classmates, in our communities, everybody's on their phone, hooked up to the computer. In fact, 100% of the time, something is going on by social media. I want to welcome and thank everybody that's also online. And as you're online, I'm sure you're doing other things, right? As you're here, some of us are probably doing other things. But what does this mean? We're in this sort of creator economy, right? There's always the next thing that we're tweeting out or the next thing that we're showing. Everybody wants to be seen. In fact, we don't have any more private moments. AI tools are beginning to produce confident and reliable outputs. And just to prove it to you, that photo, where do you think I got it from? ChatGPT generated it based on what I told them the abstract of this talk was going to be. But there's also intentional misinformation or disinformation campaigns that are done. And this fragmented expertise of those of us in our profession that are supposed to be the gatekeepers of knowledge. We're not trusted to be the gatekeepers of knowledge. Patients and families are also triangulated between the influencers and us. So those of you that are online, think about what you've seen online as having reputable information from and who you've gotten that reputable information from. So forgive me, but my children were running around chasing after Kim Kardashian, talking about how she became a lawyer. That's not the reputable way of becoming a lawyer, right? And so I want you to think about how we see information. On our phones, which now has the ability to have Copilot, ChatGPT, you name it. On this side, it says, what's the risk with long flights? Well, long flights are generally safe for most people. Just remember to stretch and stay hydrated. Have a great trip. Or long flights may increase the risk of blood clots. It's important to move around and drink water. Consult your doctor if you have concerns. Is there anything wrong in what either one of them said? But how do you think the first one on the right is being pushed out, and pushed out by who? And I'll tell you, the message on the right comes to me frequently as I'm flying with my airline, right? That's not medical information. It is true, but it's a very different message than on the left. And if you're the average consumer, would you want to fly if you're going to get blood clots? So you like the message on the right. But that reminds me to tell you that we're constantly talking about mistrust. That's because we lack faith. But what we're also facing is distrust. That I lack faith because of my own unique experiences that are grounded in culture. And so this is a great place for us to be at Emory and the Bioethics Center. And we know when we look at bioethicists, certain cultures will not trust us, not because of mistrust, but because of distrust. And so I also want us to think about the anatomy of trust. I train a lot of nurses and physicians, so excited to be an inaugural dean, and we are going to be training midwives and family nurse practitioners and physicians, and even as clinical ethicists, the relationship that I can build in 30 seconds, 1 minute, 3 minutes is invaluable. And that relationship is sometimes colored by how we talk or how we don't talk, sitting in silence. But let's think about that. As we look at it from an ethical lens, I want to know that you're there for me, that you're benevolent. So when we think about ethics, we're now working on standards and training, but for most of our programs, we don't get paid. Patients trust us because we're there for them. Is that the same way you feel about your plastic surgeon? Are they there for you? Maybe. But a $30,000 facelift makes you think differently, right? No, I haven't had one yet. I'm trying to save up for it. Competence, right? That you really know what you're doing, that I trust you in what we're doing. We train a lot of trainees. I know myself, when I encouraged to get clinical care, I would always let the trainee examine me. In fact, when I delivered my daughter, let the nurse practitioner student examine me. And whenever they were looking at the screen saying, oh, we think you're this or that, no, go away. Go get the physician. Go get your P, right? Did I trust what they were saying? No, because they're training. But we expect that we can trust our clinicians. But clinicians are going away in droves. Organizations are buying out clinical practices. Nurses are staying at the bedside less than 5 years before they move to advanced training. So that competence is in question. Integrity. We expect people to be honest, right? Some of the things that we faced as clinical ethicists is truth telling, right? Please don't tell mom that she has cancer. And what do we always say? If mom asks us directly, we're going to be honest. So I go into mom and say, if you were going to have a bad illness, would you want to know? Oh, why are you asking me this? Please don't tell my daughter that I have cancer. So they both know, but they're living in this not knowing, dishonesty, omissions. We can't do that as clinicians. And so we want to be honest, even when it's uncertain. And there goes the problem. Think about 5, 6 years ago during COVID, when we didn't know everything, when there was a lot of uncertainty. Were we honest about what we did not know? Did we create a sense of mistrust or distrust? Because every day something was changing. Transparency. Let me know how you reached your recommendation. And this is becoming very interesting right now, right? Because if we were sitting in a clinical office, there might be ambient listening, and my voice might be being transcribed into a patient's chart. Does the patient know that? We laughed and joked about the hot mic, right? Because once the mic went on, I had to kind of stop talking about things that I was saying, right? But the hot mic is always there. And if we are using it in different ways to come up with our recommendation, that honesty needs to be there. So in other words, trust with our patients. They want honesty even in uncertain times, and they want to know that we're there for them. So let's talk about the ethical frame, because this is an ethics talk. You've seen principalism, where we talk about the 4 major principles or pillars: autonomy, beneficence, non-maleficence. But I want us to think about trust in terms of justice. And that justice, that fairness, that equity, there's a tension there between my individual self-determination and community self-determination. So I laughed and joked about ambient listening and going to that EHR, that electronic health record. Is that accessible to everyone in terms of when they leave the office, they can read what was said about them? But what if you are in a desert, in terms of technology deserts? Then what I've written in a chart about you, you can't see. Okay, I'm going to tell something funny about my daughter, because I always do whenever I talk to her. My daughter has a crazy mom, a mom who does many things. And one of the things that I did was a lot of reproductive justice. And so in doing a lot of reproductive justice, I had my own GYN clinic. My daughter, from a young age, would check in my patients. So she knew everything that needed to be done about a GYN visit. I'm also someone who was raised by a Southern mom who raised 4 daughters. So there's all of these deceptive practices that parents do that ethicists can't do. So here's the deceptive mom trick. We have really horrible cycles. So from a young age, when my daughter hit, teenage years in high school, I gave her low estrogen to control her cycles. And then I told her it had iron, which it did, but that it was not anything that could ever help to prevent pregnancy. So because it was low estrogen, She goes off to college. She meets the man of her dreams. And she comes back and she says, Mom, I saw the nurse practitioner GYN provider. And she wrote in her record all of these things. And she never did this teaching about this and that and that. I want to correct my record. I said, that's really militant. Wonderful. I said, but why did you go to the NP-GYN provider anyway? Oh. I said, I'm looking in your record because she's showing it to me, right? She said, you asked about your low estrogen. Why? She said, because you told me it would never protect me from pregnancy. So I said, I don't think I want to have this conversation. But to say to you that idea about how we access information, whether it's equitable, is not, right? So my daughter had something other people didn't have. She's had access to healthcare. She had a healthcare provider that taught her about herself. She knew how to read her electronic record from a medical standpoint. So when we talk about equitable literacy, we wonder why people distrust us, because we haven't given them the skills or the access they need equitably. And when we think about that equity-minded framework, language access, do we speak in plain language? Do we always have interpreters? Do we have providers that look like our patients to be able to have some cultural rapport? Do we acknowledge the harms? Do we even inquire about it? So you're distrusting this information that I'm giving you related to your gynecological care. Why is it? Because my mother, my grandmother may have been sterilized against their will when they had their fourth or fifth child. We act in America like they're things we're not supposed to talk about. Like I just said to you, I didn't want to have that conversation with my daughter, but I did. You know, that's the New Yorker in me. I said, well, did they give you condoms? Are you being safe? Did they do an HIV test? Right? But not everybody does that. And what I'm saying, the distrust that's being created, that's shaping that distrust, is the elephant in the room that we need to talk about. And sometimes, as clinical ethicists, that's what we bring to the team, is to be able to put out into the open the hidden values and beliefs that people do not want to talk about. So the structural barriers. When you think about how clinicians are in visits and the amount of time that is allotted to that visit, the first thing that we hear from organizations is that it costs too much to talk. You believe that? Costs too much to talk. So we sometimes need to invite our community in to anchor to that trust and create that dialogue away from the hospital and away from the office visit. So I'm also going to talk to you about a couple of tools. One that's kind of near and dear to my heart because it says nurse, but anyone can use it. It's name, understand, respect, support, and explore. I'm going to talk about that exploration. And the other is ask, tell, ask. Ask the question, tell the information, ask it again, and teach back. We need these things because there's a lot of uncertainty. A lot of what happens to you medically, clinically, is we don't know. I always love thinking about that if we knew what was going on in our bodies at all times, we would be completely healthy. It's never what you know that is going to kill you. It's what's going on in your body that you don't know. And so when you come into a clinical arena or are brought into a clinical arena because of tragedy or because of a symptom, instantly we have a suspected feeling of what's going on with you, but we don't know. So for all the clinicians that are listening to me, be careful what you say to a patient and their family in the first 5 minutes of meeting them, because you can't take it back. When you tell me you know that I have something that is going to end my life in a week, and 10 days later I'm alive, what do I not do? Trust you. And when that's happened to my mother, my sister, my brother, and my father, and you say it, I really don't trust you. And we've all had those experiences. My sister has a form of heart failure that comes not from having high blood pressure, not from being overweight, from it being genetic. And 15 years ago, her physician told me she had a 25% chance of living 2 years. I knew from the textbooks she had a 25% chance of living 1 year. Notice what I said to you 15 years ago. And she's still here. And my biggest champion, making sure that I connected to Kathy in Georgia, right? What we don't know colors our lives. And it's not that my sister was a miracle. New drugs came around, right? But when we talk to patients, why are they afraid of us speaking with them as ethicists? Because they don't want us to take away hope. Well, you don't take away hope in truth. You take away hope in uncertainty. Because when you're uncertain, we should not act like it's a fact. So let's play around with some cases, because I could go on talking all day and this isn't good. I want us to have some interaction. 28-year-old pregnant patient declines her recommended videos, vaccinations. This sounds familiar? She's watching TikTok videos who say that these vaccinations are going to cause the fetus some harm. She brings screenshots into the hospital, and these screenshots, and asks if the hospital is sponsored by, you name the pharmaceutical company. Because now it's the pharmaceutical company that's pushing the vaccine that's harming her infant. Okay, unfortunately, that is not too unique. This happens a lot. So what do we think about that? That's okay, I'm frozen. Thank you. So what are the ethical issues? If there are any. And somebody has to shout one out.
Is she adequately informed? What's her source of information?
Mm-hmm. So a source of information, her autonomy, right? Any other ethical issues?
How do we manage the relationship with the patient and their appropriate clinical care?
Mm-hmm. So how are we going to manage this relationship with this patient? Are we just going to say, you're watching TikTok? Who does that? No, I'm teasing, right? So we don't want to be dismissive, right? The other issue that we have is we've got two different autonomies here. The autonomy of the mother, but potentially fetal autonomy. And depending on where we are in this country, fetal autonomy is either held prima facie or not. So there are some times when I give this talk that some people might say she's medically neglecting her fetus. Others might say it's her autonomy, she shouldn't have a vaccine. Others might even say that she's right about not vaccinating during pregnancy. What is she to believe? So I want us to kind of think about, if we look at case one from the point of view of the ask, tell, ask, and let's think about the equity lens. You mentioned this, Kathy. Where is she getting her information from? Does she have access to information? Does she have access to good clinical care? The transportation, right? Where is she going? Is it in the local area that may be a desert to having great prenatal care? childcare, acknowledging the historical mistrust. There are lots of things that are going on inside the head of the 28-year-old that we may not know. So let's do the ask. Can you share what you've seen and what worries you the most? Right? What is it that she's seen that worries her the most? Is it the potential relationship with pharma and the hospital? Is it the vaccine? Is it her fetal care? We've got to figure out what it is without putting that judgment. And then the tell. I don't like telling because telling feels very paternalistic to an ethicist. So I say tailoring. Let's tailor the information to what you need. Here may be some of the real good studies, and then for people like you, maybe, or for people in your situation. And then ask the check. How does that line up? What additional information do you need? The tailoring is really important because sometimes we feel like if we give so much medical information, this is going to get through the distrust. And one of my great colleagues in New York always taught me that people don't make medical decisions. People make emotional and social decisions. They make decisions out of love. They make decisions out of finance. They make decisions out of what's going on in their lives. But they don't look at the study and at the drug and say, this is what works best for me. I want to stay here. I want to be here because I want to be here for my future grandchildren, not because of what the drug says. But let's look at some clinical ethical issues for ethicists that we frequently see along the veins of this vignette. The refusal of vitamin K for the newborn. Many of us have different policies in our different organizations about when a mother refuses vitamin K. In the state where I came from, we were allowed to give that vitamin K even if the mother refused. And you can see that caused certain fractures of women not coming into the hospital to deliver, staying at home because there was no latitude to explore why or when. The refusal of measles, mumps, and rubella vaccination in pediatrics, and what that means when you go to school or in certain communities where there's a high rate. Maternal refusal of medical recommended treatments. And the biggest one that we see is the refusal of a C-section. So you can see how that can play out even for an ethicist. And the interesting thing is the third thing that I told you about maternal refusal of a C-section. We've had legal cases where we said, okay, the woman is incompetent. She lacks capacity. So her husband can make that decision. No, he can't. And so we frequently turn to the law for answers to these questions, but clinical ethicists exist to prevent this from being legal, to begin to speak to the woman, to her partners, and understand the values and beliefs that are behind it. And sometimes it's not an either or, it's not a now, it's a future. So what are some of the things in case one that we could do so that trust isn't on trial, so that we can build that trust? Sometimes visual handouts are better than language. Sometimes a picture does say 1,000 words. Sharing your reasoning path. We do this often as clinical ethicists where we try to break down benefits, risks, alternatives, and sometimes the alternative is a time-limited trial. And if declining today, it doesn't mean that you decline always. But really, I think one of the things that ethics brings well is the lens of community participatory engagement. It is not health that is going to make the difference. It's not medicine that's going to make the difference. Sometimes it's the pastor. Sometimes it's the trusted grandmother in that community. It's really bringing the community in, inviting the questions from the community of what's going on. So let's play with case 2. This happens in oncology. Patient uses a popular AI app. You choose it. They change often. And they get a confident recommendation that goes against the tumor oncology board that has a different treatment plan for this patient. Family now doesn't believe that the tumor board or the oncologist even know what they're doing, and they want the AI therapy that said that's not available at your center. We faced this as well before, and some would argue, what do you do with a patient that doesn't take your medical recommendations? Shonda, what would you do with a patient that doesn't want your recommendations?
I mean, I would respect that and tell them that if they don't agree with me, that they are more than welcome to find alternative individuals to contribute to a resolution.
Yeah. That's usually the common answer, right? For those of you that didn't have it, you can get a second opinion. I'll say it in a different way. You can get a second opinion. But what happens to a person that's getting misinformation with the second opinion? Is the second opinion going to be any different than the first opinion? And then now they're lost to care, or perhaps delayed in care. So the answer is totally reasonable and totally right. We always say physicians are not obligated to perform treatment where there's expectation of harm more than benefit. However, what's happening is there's a third party here, a third party that's not even human. You can't even pick up the phone and argue with them. So these ethical issues, and I put them together. Generative AI has hallucinations. You can play with it as often as you can, but it's the prompt that gives you the answer. You put in the wrong prompt, you get the wrong answer. How is a patient supposed to know not to trust this information? I gave a recent talk for our convocation, and we were going to be in the Martin Luther King Chapel. So I just asked AI to give me a quote. It gave me a quote that he never said, you know? And I told the students, I went, ChatGPT told me this, great quote, but he never said it, right? It's the same thing here with medical information. It is combing information based on a certain subset of patients, based on research that is out there. It does not know it's good research or bad research. And so ethically, that brings up a lot of issues in this case. What is doing well for this oncology patient? What is beneficent? Is it challenging the information? Is it getting another opinion? And think about that in the paradigm that we have here in Georgia in terms of pulse. So there currently is a patient up north who was brought from Georgia up north from hospice for a second opinion based on ChatGPT. So the conversations that we have become very, very important. So let's try this different form here. And this gets to what LaShonda said. It's reasonable to compare options. I'm going to acknowledge that what you're asking is totally reasonable. Our plan came from a multidisciplinary review. Here's the evidence. I'm going to give you the evidence that we used. In other words, I'm going to explain it. And then we say, here's what we can safely offer. Here's why this therapy may prevent harm. So I'm not just going to send you out the door. I'm going to give you that explanation, acknowledge your feelings, and offer the second opinion right here. You still may not take it, but the idea is you feel heard. anyone that gets clinical information is going to question it. So I'll tell you myself, because I'm always an open book. I gained way too much weight being pregnant both times. 90 pounds the first, 60 the second. Me being a nurse who knew and taught Lamaze, I pushed against a contraction and I ended up with a tumor in my right lateral rectus. Okay, I felt it. It was there. But what could that be? Now I'm a nurse, right? What do nurses do? Has to be the worst. So was sarcoma. It was a form of cancer. You know, I did the living will. I actually convinced my husband that we needed to turn over custody of our children to my older sister because I didn't trust him when I was going to die in 4 months. I arranged to get the best oncologist, the best plastic surgeon, best GI, and they actually did the biopsy. And the day before they did the biopsy, my white blood cell count was very low, which I don't know why it was very low, but that was proof it was cancer. So I delayed the surgery by a month because I had to get everything in order. What happened? I had something called aggressive fibromatosis, which is that I kept keloiding in the muscle and I lost the muscle. It wasn't deadly in any way. I got a nice tummy tuck out of it, but I was on that pathway, right? I needed a second opinion. I needed a third opinion. I needed another MRI, right? Because they're telling me it's contained, it's not cancer. No, you don't know what you're talking about, right? So it's reasonable that people have in uncertainty, they are thinking in these emotional, social ways that feeds back onto distrust. There was only 2 people I was going to trust to go in my gut that I knew for more than 10 years. And I waited to get on their schedule, right? Distrust is not a bad word. What is bad is being disparaging about that. That's what ends up being a clinical ethics consult. So I want us to think about, and we're going to do these together. We're not going to break out into any small groups, but I want us to think about the perspective of being the clinician versus the patient versus just the observer, the standby. And the reason why I want you to think about the observer could be the student. The observer could be the nurse. The observer could be the ethicist. The observer could be the respiratory therapist. We forget that this interplay that patients have with their clinicians feeds over on the interdisciplinary team and causes moral distress. And so we're going to think about, from an observer point of view, what does equity and trust behaviors look like? And we're going to kind of debrief on what language could we use that not only reduces defensiveness, but we talk about autonomy as self-determination. I want us to also think about autonomy as dignity and as agency. And when we say agency, what made me feel really well about going through that 6-month procedure and now not having a muscle is that I was in control of my own care. And so when we think about the best thing to put trust on trial is to create patient agency. So here's our case that we're going to do together. This one's probably more common in the clinical ethics world. Surrogate wants some ICU therapy. I'll tell you the one that they really, really wanted. They wanted to do a therapy with a fecal transplant for an unknown reason, right? Not to protect or re-put gut flora in from having an infection like C. difficile. This was going to treat the cancer. And that was based on a viral post. True story, viral post. It was all over Facebook that this worked. The team was like, what's the harm? We've done it before. If we don't do it, this family's not going to trust us. The bedside nurses were like, we ain't doing this, right? Because what are we doing it for? When we sometimes think about placebo effect, right? Placebos are deceptive. And there's rarely any place in medicine for a placebo. Maybe to confirm what we think might be malingering, but then immediately after we do something like that, we got to be honest and say we did it as a trial to test A, B, or C. So there was going to be no honesty in this to the unconscious patient. Okay, now that I've probably given you an editorial that I shouldn't have, right? Let's think about it. The nurses are the observers. Where is that moral distress coming from? And at any time, if anybody chats in on who are online, please chat in if you have a comment to make. And you can raise your hand and unmute yourself if you have a comment. But those in the room, from an observer standpoint, what is going on here with distrust or mistrust?
I think nurses need it to make sense. Like if I'm gonna do something for a patient, it needs to make sense of why I'm doing it, other than just because the patient wants it.
Mm-hmm. So I'm going to repeat it just because of where you're sitting. The nurses need it to make sense. They need to know the why. Not just that we're doing it, but why are we doing it? What is the good that's going to come from doing it? Okay, that's great from the observer point of view. What is the problem with succeeding to doing something with surrogates and thinking we're going to build trust? What does it also build? Distrust. Because you said it wasn't a good thing to do. But I just showed you something and now you're going to do it? Patients and families will be angry at us, reasonably angry, and they're right, when there's a refusal for some sort of treatment. Now remember, we refuse treatments, we never refuse care. But that's integrity. The minute that we decide, yes, we're going to go ahead and do it, but why didn't you do it yesterday? Was it because it cost something? Was it because I argued to this one? Was it because the more seasoned clinician came in the room and convinced you? So the minute that we do that, we immediately erode trust. Because that means you didn't even trust what you were telling me. It's interesting that that's that two-sided coin. Just like in ethics, we live in the gray. There's no such thing as you have trust or you don't have trust. It's like a cheating spouse, right? You trusted him yesterday. It's not that you don't trust him. You're somewhere in the middle, right? Trying to figure it out. That's what this is. What about this one? You've got an elderly person with limited English proficiency. They receive circulating voice notes, and voice notes are true, right? You can put something on your phone to change it into an English language or another language. It warns against hospital oxygen. So the family on their behalf doesn't want a pulse oximetry because they don't want to end up needing oxygen because they don't trust the oxygen. In other words, do you change a plan of care that you ordinarily do as standard because someone distrusts what you're doing?
An opportunity for finding out more about, again, the voice notes and providing further information, but acknowledging.
Mm-hmm. It's so true. So if we think about it from the tools that we learned to acknowledge that many people are concerned about the use of putting on something on their finger to check their oxygen. but I am using it because grandpa's, and notice I made him human, he's not just a patient. Grandpa is suffering from a problem with his lungs that could be affecting his oxygen. So I need to use it. So what I want us to get from this is to classify. That was you or me? Okay. I like it. That was good. Okay. First, the thing that we have to know is the distrust benign or serious? What is a benign mistrust? You know, I just don't like people who come in with red pants into my room. I mean, is it really going to affect my care, the red pants? No, it's not affecting the treatment plan. Low risk sometimes can be delays. What is the delay in care that's going to happen? Because I asked for this extra MRI. Was it really something that was going to change the overall outcome of my health? No, because the clinicians really believed that it was aggressive fibromatosis. They were right. It was only Renee's brain that thought that she had cancer, right? But the high risk harm, what if they really believed I had cancer and I was delaying my care? So we first have to really know, is this a high risk? Think about the patient that we talked about that was oncology, that wanted to go for that second opinion. If I really consider that a high risk harm, I'm going to help them get the second opinion quicker than letting them do it on their own. Still acknowledging that mistrust, but really classifying that. This is something that we always really talk about, assessing capacity. Can I make the decision specific to what that is? And I want you to think about capacity very, very differently. I want you to think about that capacity is specific to the decision that you're making. And if I'm really standing here and being honest with you, when my daughter was 3 years old and my son was 6 months old, and I'm finding out that I had a tumor, was I communicating? Yes. Did I understand? Yes. Did I appreciate medical facts? Yes. But was my reasoning logical in the way it is in 2025? No. Now, psychiatrists would have come in and said, doesn't have capacity, but it's not a blanket thing. So again, we have to use a threshold. The higher the harm, the more capacity I need to demonstrate. And just because I didn't have perfect capacity at that moment didn't mean that I couldn't get there. Because someone could have sat there and talked to me and said, acknowledged, Renee, this must be really fearful for you, having lost your mother a few months before, having a 3-year-old and a 6-month-old to be undergoing what you believe is cancer. That didn't happen. Why did it not happen? Because I was a nurse practitioner, right? I had access to healthcare. We cannot make assumptions when it comes to capacity. We also cannot make assumptions at the intervention that needs to occur. So I wish I had Kathy back then as my clinical ethicist, right? Who would have sat down with me, and in 10 minutes, that sense of dread, the sense of hopelessness could have been pushed to the side to get to the practical things that I needed to do. And I would have got my tummy tucked 6 weeks sooner. No. So we also have to map evidence in the way people need that evidence. It's not always going to be an article. Sometimes it's simply what I said, the intervention of sitting down and let's talk. And then we have to select the response. And sometimes responses for clinicians are not going to work. One of the great things that I did in my former life was have algorithms in the ER, in the emergency room, because there were certain situations that we knew, whether it was going to be children, whether it was going to be people who lacked decisional capacity, either due to intellectual disabilities or dementia, that it would trigger the ethics escalation, just for the ethicist to be there proactively to come and check on that family. Because the nurses are doing it, they don't have time. The medical students are doing it, they don't have time. And what we see in them is the moral distress. Not that moral distress doesn't happen for the ethicist as well, but the ethicist has time. And then we need to document information that's shared, as well as how people and why they're making the decisions that they're making. So there are 3 levels to this trust on trial. The clinician level that we talked a lot about, but we can't forget that there's team level dynamics. We function in teams as an interdisciplinary team. Every voice matters. Every voice has a different perspective. And if we function that way better, we could give consistent messages and handoffs between day and night. And even better, we could help in that team address some of the moral distress. But the other part is the organization. The organization has to be committed to creating that trust. And not just as people come in the door, but in how we interact and participate and engage communities. And also how we track disparities and how we are transparent with the policies that we create. I come from a state where if a physician suspects that you are dead by neurologic criteria, which is brain death, they're allowed to declare it. So I'll tell you a quick 2-minute story, a story you may have already heard many times. Jahai McMath, who is in California, who became dead by neurologic criteria after having a tonsillectomy and an adenectomy. She was declared legally dead in California. Her grandmother was a nurse, and she was allowed to be put on a plane by a coroner, hooked to a ventilator, and she came to New York, to Medford, New York, where I lived at the time. She got a trach and she got a peg, and she left New York within 6 hours. And you're gonna ask me why. Some of you know why. Because if she stayed any longer, she would have been declared legally dead in New York. She was transferred to New Jersey, where New Jersey allows families to opt not to do brain death. She was dead federally, but alive in a state. She didn't qualify for Medicare, but she qualified for New Jersey Medicaid. And that created a horrible uproar in New Jersey. Transparent policies, right? I don't think that in my former state, we were very transparent with anybody. All clinicians knew that. And that was the way we got through clinical ethical issues related to brain death. We had reasonable accommodations. And everybody would ask, what's reasonable accommodations? Whatever you made it to be. And so without transparent policies, disparities are very different. So I can tell you that if you were Black and brown and brain dead, you didn't have much accommodation unless you had money. And what were you then allowed to do? Take your family to New Jersey. So we have to measure the progress. Really do those post checks with your patients. Really keep equity metrics, and this is a little challenging now in our current CDC, but we do have SVI indicators so that we can look by race, ethnicity, and zip, and really do frequent check-ins with our staff qualitatively to know how they're feeling in terms of moral distress. And so some of our legal touch points, just is informed consent is informed consent, and we do have the right for informed refusal, but we have to disclose the limitations of AI. We have to avoid over-reliance, and when we are using it to read x-rays, to do certain things, we need to be transparent with the community. And we have to, have some boundaries for non-evidence-based reports. Not everything that we do in medicine is based on evidence. I always tell my students, when we have somebody with hypertension, we tell them that you need to be on a low salt diet, a 1 gram sodium or 2 gram sodium diet. It's never been researched. It's just something we believe. So if we have these practices, these sacred cows that we hold dear, then we have to acknowledge that patients have those same sacred cows that they hold dear. So start with ask, tell, ask, name the emotion, acknowledge the emotion, use teach back, be clear, respectful, have follow-up, and also think about the use of interpreter services, ethics consult pathways, algorithms like I told you about, like triggers, so that when we know when to call ethics proactively. Because trust is built encounter by encounter through curiosity, transparency, but a shared purpose to being well. And I want to thank you. And I also want to acknowledge that, yes, ChatGPT did help me. And I tell you where, it made that photo, and it was a good photo, so I used it. But everything else comes from the human experience of knowing that how we make decisions is not medically. It's emotional, it's social, and it's mired in complexities of everything that we are. So Kathy, I can't thank you enough for allowing me to be here, and I'm open to any questions that you may have.
See, there are a number of things in chat, so I'm wondering if there might be some questions. I see Lauren Nunley has her hand up.
Thank you, Lauren. She's giving me a clap. And in true transparency, I rely on her so much. She's my director of clinical strategy and transformation at Morehouse School of Medicine.
Alison, are there some questions there that?
No, I don't see any questions, just the comments in the chat. Okay.
I'll ask a question.
Yes.
One of the short statements you said was the ethicist has time.
Yes.
And that really struck me because there's less and less time that the actual clinician who may actually make the ultimate decision about the medical care has. And so in this complex world we have, is there anything we can do about it? Right now, my understanding is that, well, on our ethics committee, at least, people aren't paid extra for doing a clinical ethics consult, right? So at some point, I worry that as hospitals have financial problems, that it would be like, well, we have to have a price tag on the ethics consult because it's important. And if it takes a lot of time, that price tag's going to be high, and then maybe your time will get less, like it has for physicians. So that really scares me with the model that we have for business.
Yes. It always scares me, and I think in a different time, I'll give you that talk, because we know the reality is that ethics is frequently on the chopping block. But I'm going to go out there and I'm going to tell you my heresy. In my other part of my life, when I run an ethics service, we do charge for ethics consultations in the way that's allowed by insurance companies that do not cost patients. So when we have goals of care conversations or those sort of things, it is billable. But the second part that I encourage all ethicists is that we save time and we save money. So I firmly believe that healthcare in this country is mismanaged. And how do I say that in a nice way? We take the person who's making the most money in the hospital, you name it, let's make it a neurosurgeon. And we ask that neurosurgeon to do something that they're not comfortable doing, which is talking with the patient around the transition of end of life. And so if we deployed the people who really need to have that conversation and pay them, like the ethicist, that neurosurgeon would have more time and the families would feel better supported. And when they felt better supported, they would come to the hospital sooner. So I think we have a backwards health system that we keep asking the people who are not trained to do things to do it, rather than the people who are. Ethicists are expert communicators, and they're expert cultural builders. Let's let them do the job that they learned and are paid to do, and stop having everybody else come in and try and do it. But that's the Renee soapbox. Not Morehouse, not Northwell, that's Renee. Thank you for that question. Yes.
I had a question about case 3, I think it was,
Mhm.
where the surrogate is asking for a certain kind of intervention that isn't being offered, and you sort of were vague about what it was in the case. I think it was an ICU intervention of some kind. And one I think illuminating thing you said about that case was, sorry, I'm ranting here, but it
Yes.
was that even, you know, the team might feel like accept, like, you know, some of the team, not the nurses, might feel like performing the requested intervention would help build trust, or at least reduce. But you said, look at the other flip side, right? Like the surrogates now, like, how come this changed from today versus yesterday, right? And so my question was, you know, how do you balance like these two sorts of considerations about trust, right? And do you think they can vary based on the particular surrogate? So that's the first question. The second question is, do you think it would vary if the intervention was more minor, right? So maybe it's something like, I don't know, they want, I don't know. Sometimes I've heard things like, "Oh, we want to like give like this like herbal concoction, right? That is innocuous or something. We think this is, you know, this is something that our family believes in, or something like that, right?" So the question I had in mind was, so two parts of the question. One is about how to balance the concern about maintaining trust and eroding trust from these two concerns. And the second question was about, do you think it varies based on the kind of intervention that's being asked? And in particular, does it vary if you kind of drop it down to something that's...
So I love your question, and I'm going to take the second part first.
Okay.
Because I think the thing that's more important isn't the innocuousness of the intervention versus the harmful of the intervention, as to the communication about why you're doing that intervention and acknowledging the uncertainty. So you use the term innocuous because cultural, I just want to make sure that they have this vitamin that my grandma swore by. I'm going to respect that for you because that is your culture, and we are trying to build this patient-centered approach. But for us medically, it is not going to change the outcome. That's a very different thing than saying you have this particular thing because you read it somewhere and this is what I want. And even in terms of culture, we respect culture, but culture is not always absolute. So think about the pediatric patient who happens to be a Jehovah's Witness and their families refuse a certain intervention. We always look at the interest of society to protect the person who doesn't have capacity. So the second part of your question is a little easier than the first. It's balancing the erosion of trust. And one of the things that I worked on in research really is uncertainty. Uncertainty is that black box between I know this is right, and we should not do this. And so that's why I said that there's always that threshold of harm and a threshold principle. If I absolutely know it shouldn't happen. And what I always say to the medical students is, now I'm of a certain age, my right knee hurts. It hurts most of the time. In fact, my boyfriend's name is arthritis. Arthritis. Anyhow, if I went to any clinician that's listening to me and said, give me fentanyl, oxycodone, and a patch for this arthritis in this right knee, they absolutely wouldn't do it. And if they did do it, it would be malpractice because it's clearly not indicated. The clearly not indicateds are really easy to handle. What you're bringing up is how do we journey with people through the middle? And that's the key. We journey with them through that ask, tell, ask, or nurse algorithm so that we're being really transparent and honest about the uncertainty and also clearly transparent about the availability of clinical trials. I told you about my sister, but I also didn't tell you that I was the one finding the 5 clinical trials and the one that she was accepted through. Shouldn't have been me, should have been the team. I hope that answered you.
Right, sort of a sensitive communication question.
Mm-hmm.
You have, throughout the talk and then at the end, you identify certain communication tools and techniques, which I think are really powerful. And much of them, of course, undergird the idea of the power of communication, period. So, you know, ask, tell, ask. What I myself, as a clinical ethicist, really trying to be attentive to is the words that are used, right? You
Words
know,
are important.
and how, you know, you have to be very attentive and listen for the ways in which you believe the next word you say either may resonate or it's a very careful, thoughtful place, and then you listen, right? You're getting the information back, and you know where to go, or you don't know where to go. And I think particularly when you go into a hospital room or outpatient, and they don't know me from anybody, and I would not blame them at all for not having any trust in me. I'm going to have to,
Earn
in
it.
a relatively short period of time, establish a little bit of a relationship enough that they go, well, this person at least is listening, is at least seems to be interested in my well-being, you know, very limited kind of goals, if you will. But just any wisdom or the words, the language, the listening, you know, these early ways to say, I'm really hearing you. And I also know you don't know me. And I'm, you know, I'm moving in that direction to let you know that I hope to be someone that can be helpful.
Yeah, I love that question because it is a skill. And I'm going to tell you at the end how I learned that and a more powerful mess up. But going backwards, I think it's a journey. And some of the consults that I dislike the most are the ones that are really urgent, where the train has already left and they need an immediate decision. And I almost feel like I'm the policy lawyer person. I much prefer the consult where I could come by the room and just wave and say hi. And then maybe a few hours later, drop my card there. Do you mind if I sit down? Because it's all of the things in not talking and just being the face and being the continuum that may make the person reach out. Second thing is that I expect anger and I acknowledge anger. And I acknowledge that the first time I may walk in the room, I may be getting all of the venom or the word vomit from everything that went wrong during this hospital stay. but that the next day or hour later, it is going to be better. But I'll tell you in the messing up, sometimes we don't know how to just be silent. And the word that I hate the most is suffering. There's a statute that we had that talked about when people are having extraordinary burdens or suffering, they meet criteria for A, B, or C. So I'll tell you my mess up. My former husband's family comes from Eastern Europe, Greek Orthodox, they're Romanian. I knew a little bit of Romanian. And I was called to be the ethicist to work with a family that was Greek Orthodox, whose mother was unconscious, who they were not going to be putting back in an external pacemaker. This pacemaker had been in too long and it needed to come out. And so I met with the entire family, the 9 children, and of course, the Greek Orthodox priest. And we went through the prayers that I was very familiar with, and I had them talk about their mother, and then I used the word, yes, we don't want her to suffer. At that, the priest stood up and he said, thank you, Dr. McLeod, because she is suffering. And that is what she needs to be close to God. So let's continue doing this, because in her suffering, she will get to heaven. And I left the room realizing that the words that I had used had the unintended purpose. Why do I tell you that story of my biggest mess up? Because I think sometimes we don't know what to say. We're not familiar with the culture. And sometimes the listening builds more trust. The asking, tell me about what this means to you. Tell me about what you'd like to hear. And the listening builds more trust than anything. The fact that we are sitting down and not rushing out of that room, not having the cell phone in our hand, not having the cell phone with us, sometimes not wearing the white jacket, and always saying, here's my number. The one more controversial thing is that my fellows often ask me, how do you introduce yourself when you go into the room and you say, I'm an ethicist? Because that means something very different to a lot of different people. So I get the luxury of saying, I am a clinician who is here as an ethicist. We don't tell you what to do. We're here to listen, but I'm not part of the treatment team. I'm here to represent, and I always make that representation, your mother, your father, your sister, your brother, their voice. And so what I'm trying to really get is their voice through you. Because ultimately, they are making the decision, and you are the voice of that decision. But that has taken me 14 years to perfect. I did it really badly. But that, to me, also takes away the caregiver burden, because they always feel like they're making the decision. And me pulling some of that burden away from them, you see the shoulders kind of drop down. Tell me more about their decision. But they can't talk. I said, no, they can't. But you are going to speak to me as if they are talking through you. This isn't your burden. I'm trying to figure out if they could talk to me right now, what would they be saying? Thank you. Well, I've thoroughly enjoyed this. I thank you all that are here in person. I thank you all that are here in line. And I thank you all for whoever will listen after. This has really been a pleasure. So thank you so much.
The preceding program was brought to you by the Emory University Center for Ethics.
The preceding program is copyrighted by Emory University.